Hello, everyone, and welcome to our final session of Kidney Action Week 2026, Get Your Questions Answered, a Q&A with AKF's Chief Medical Officer. My name is Mike Spigler, and I'm the Chief Program Officer for the American Kidney Fund. I'll serve as your moderator for today's session. Whether you want to learn more about a topic you've heard about this week or still have questions about kidney disease, you've come to the right place in this session. Before we get started, I do want to give one disclaimer. The information that's going to be shared in this live Q&A is for educational purposes only, and it is never intended as medical advice. Please consult your healthcare provider for guidance on your personal health. If you have specific health concerns, please reach out to your doctor and in case of emergency, seek immediate attention. During this session, please type your questions and comments in the chat to the right, and we will try our best to get as many as possible. I am thrilled to now welcome our Chief Medical Officer, Dr. Pranav Garamella, who will be answering your questions about all things related to kidney disease. Dr. Garamella joined AKF as Chief Medical Officer in January 2025. A nationally recognized leader in nephrology and an expert in rare kidney diseases, Dr. Garamella provides high-level clinical authority and insight to better serve the 1 in 7 Americans living with kidney disease. He is a board-certified nephrologist and the Director of Acute Dialysis Services and the Polycystic Kidney Disease Center of Excellence at UC San Diego Health, where he provides care to patients with a wide range of acute and chronic kidney diseases. Dr. Garamella is an established researcher and serves as co-chair of the PKD Foundation Centers of Excellence Program Advisory Committee. He was a member of the American Society of Nephrology Quality Committee and was chosen to be a California Healthcare Foundation Leadership Program Fellow. Thanks for joining me today, Pranav.
Thank you so much, Mike. It's my pleasure to be here, and I look forward to our session today.
Great. Well, as a quick reminder, I want to encourage everyone joining to please type your questions and comments into the chat on the right. And while those are coming in, I'd like to kick things off just by recapping some key information from the week. And if you've missed any sessions this week, you can already find the first few days of Kidney Action Week on AKF's YouTube channel. But first, Pranav, let's just, if you could remind us a little bit about, what is chronic kidney disease?
Thank you, Mike. Chronic kidney disease, by definition, means that someone's kidneys are not working to the expected amount and that the duration of this has lasted for at least 3 months. That's where the term chronic comes in. And this could be a variety of causes that lead to this. You can have conditions like diabetes and high blood pressure, which have over time led to a decline in your kidney function. And the way we diagnose chronic kidney disease is that we need to usually measure both creatinine or cystatin in the blood, and we also look at urine to measure whether people are spilling albumin, a protein that's commonly present. And using these, we can diagnose and even classify stages of chronic kidney disease.
Mm-hmm. Great. Well, we're already getting questions in, and we actually have a couple of questions from the session right before this one, which is on glomerular disease that Dr. Barrett did. So a question from that session regarding FSGS. So can an antibody test for FSGS be processed after a transplant?
That's a great question. The challenging thing is that antibody tests for FSGS are not widely used even now clinically, and they are still used to try and make the diagnosis of non-genetic causes of FSGS. And yes, the short answer is you can have positive antibodies that are either directed anti-nephrin antibodies or other podocyte directed antibodies that can be positive even after someone has had a kidney transplant. But the key thing to remember is what are these titers? How were they before the transplant? How are they now? And were they associated with the development or progression of disease? So I think context is very important in which they are measured. And only in that context and at a center that has experience evaluating these patients and managing these titers, should a patient really have these questions answered.
Excellent. All right, we have a question regarding vasculitis, and maybe what I'll do is I'll ask you to just describe what vasculitis is first before answering this, but let me give you the question too. What treatments are recommended for chronic kidney disease caused by MPO vasculitis? But if you could give us an overview of what vasculitis is first before answering.
Got it. So vasculitis is a spectrum of autoimmune conditions, which means that the body's immune system is typically producing an antibody that is somehow targeting either the blood vessels or different organs. And to give you an idea, we have conditions that are called microscopic polyangiitis, we have anti-GBM disease, we have other ANCA vasculitides that can be caused by MPO or PR3 antibodies. So there are two different types of antibodies. And in these situations, you can either have vasculitis of the kidney, so the kidney's blood vessels and the tissue of the kidney gets affected. You can have vasculitis affecting blood vessels in the skin, so you might see rashes and inflammatory lesions elsewhere in the body. We can see that in the lungs, we see that in the upper airways sometimes. So like I said, vasculitis are a spectrum of disorders that are caused by an autoimmune process wherein the cells of the body are being attacked by immune cells which shouldn't be doing that. In that context, we have two types of ANCA antibodies, MPO and PR3, and the MPO stands for myeloperoxidase antibodies. So that is one subtype of vasculitis. Coming to the question of how you treat vasculitis, that's a great question. Our understanding of vasculitis management has evolved significantly over the last 30 or 40 years. Historically, if there is an overactive immune system, the first response was to try and suppress it. And we did this using heavy hitting medications that would suppress the immune system in general. The first choice was often steroids. Steroids suppress the immune system overall, but they have significant side effects. And we were then using medications like cyclophosphamide, which do a better job than steroids at suppressing the immune system in a somewhat narrower way, but also have complications of low blood counts and infections. And over the last 15 years, we've really improved our understanding even further as we look to newer therapies that look at targeting B cells and complement-mediated pathways. So rituximab and avacopan are mainstays in the treatment of vasculitis, whether it's MPO or PR3. And in some situations, there might be a role for using plasma exchange as well to manage acute complications caused by a vasculitic flare.
Thank you very much. And if you're interested in learning more about vasculitis, the American Kidney Fund has a great campaign, of Vasculitis. So we can drop that into the chat as well. And any of those pages will link you to another great organization that we work with, the Vasculitis Foundation, for more information as well. We have another question about a particular rare kidney disease, this one about Alport syndrome. I'll ask you to do the same, if you could describe what Alport syndrome is briefly, but then what kind of advances are being made in treating patients with Alport syndrome?
That's such an important question for a couple of reasons. Like you said, it is a rare kidney disease, and so by definition, there aren't as many patients who have it. And so research is incredibly important to drive advances in rare diseases. Alport particularly is a collagen mutation disorder. There are multiple collagen subtypes. The kidney has a collagen matrix in it, and when we have mutations in these called 4-1A, 2A, 3A, 4A, or 5A, these are the subtypes that we often see, and these are genetic diseases, meaning that you can pass it on from a parent to a child, and there is an autosomal recessive form, and you can have an autosomal dominant form, which means in the recessive form, you might need 2 copies of the gene from each parent to manifest the disease. And in the dominant form, 1 copy may be enough. You also have an X-linked form wherein you have patients who get the disease from the X chromosome. The hallmark of Alport is usually progressive kidney disease and protein spilling into the urine. And unfortunately, up until this time, we don't have targeted therapies working on the disease that can actually stop progression of disease. So what we currently use are medications like angiotensin receptor blockers or ACE inhibitors, and even SGLT2 inhibitors now to reduce the amount of protein. But finally, we have several drugs in clinical trials that are probably going to go further, looking at endothelin receptor antagonists, mineralocorticoid receptor antagonists. We have some NOX1 and 4 inhibitors that are being developed, and even monoclonal antibodies against a protein called SEMA3A, which are in clinical trials. And so, as we learn more about the specific subtypes of protein mutation, subtypes of mutations that these patients have, we might be able to also provide some gene-based or microRNA targeted therapies. Again, these are still in clinical trials, but the future is hopeful because we've really understood what causes Alport. So trying to target these pathogenic mutations is probably the next step.
Great. Thank you so much. Well, similar to vasculitis, there's a great foundation for Alport syndrome called the Alport Syndrome Foundation. And, one of the things that I know that organization needs to help move these trials along is to be able to find patients and understand kind of what is happening with them. They do have a registry on their site as well, where you can be informed when a trial that you might be eligible for comes open. So I would certainly refer you to them as well. More of kind of a general question. What are some lifestyle changes that a person can make to avoid going on dialysis?
Excellent question. I think this really gets to the crux of the matter, which is chronic kidney disease has a huge lifestyle component that could be modifiable to prevent progression. I'll start with things that are universally accepted. Tight blood glucose control. We know that diabetes is the number one cause of kidney failure, and ensuring that patients have a tight glucose control and they have their urine checked for protein is really important. Sodium plays a big role in blood pressure management, and patients in advanced kidney disease stages may also have edema, which is swelling, if their sodium intake is high. So making sure that patients have low salt diets. Typically, we say less than 2 grams of sodium, not 2 grams of salt, but 2 grams of sodium per day is what we recommend. We're increasingly recognizing the concept of cardio-kidney metabolic syndrome. And what this means is that we don't look at kidney disease as an isolated entity anymore, but rather a connection between the heart, the kidneys, and the metabolic milieu that we live in. And this could be your diabetes, this could be your liver health, this could be obesity. All of these are interconnected. So making sure that your visceral adiposity or central adiposity is reduced if you are overweight, making sure that your cardiac health is good by good regular cardio, and also by building muscle using resistance training, because that will improve your metabolic profile, are really key. Of course, it goes without saying that smoking is bad for the heart, smoking is bad for the lungs and the kidneys. So avoiding tobacco and limiting alcohol to the minimum are probably the big lifestyle changes that have visible effects on kidney disease and cardiovascular disease progression.
Thank you so much. And cardio kidney metabolic, as you mentioned, is such a important thing for the community to understand right now. And we've entered into collaborations with both the American Heart Association and American Diabetes Association to do just that. And you can find more information on cardio kidney metabolic syndrome and some of the work we're doing on the kidneyfund.org website. A question regarding this is something that I think a lot of people don't know about, but it's very important information to know. Can you talk a little bit about, so the question is, can taking some medicines for long periods of time cause kidney disease?
That is a very nuanced and a very important question because, again, I think it's important to recognize that some medications are necessary for lifestyle, some medications are necessary for other conditions, and they may have side effects that can affect the kidney. We'll start with pain medications, which are probably the most demonized group of medications when it comes to kidney disease, and with fair validity, perhaps. I'm talking about non-steroidal anti-inflammatory drugs. Ibuprofen, the ketorolac, naproxen. These class of drugs can have an effect on the autoregulation of blood flow in the kidney. That is the primary mechanism behind which blood comes into your kidney and goes out. And I'm talking at the level of the cell, of the nephron. And so when these are abnormal because of a medication, the kidneys can perceive over long term decreased blood supply and abnormalities in pressure, leading to chronic kidney disease. They can also cause interstitial damage, which means not just because of the blood flow, but the surrounding tissue surrounding that glomerulus, the tissue surrounding that filter, can over time get inflamed. Having said that, I am cognizant of the fact that a lot of patients may have arthritis. They may have conditions that are only helped by nonsteroidal inflammatory drugs. And so it's important to make sure that you speak to a clinician, you work with a pain team, you work with a team that can help you manage pain using medications other than nonsteroidal drugs, but perhaps also lifestyle changes. The second class of drugs that often come up are proton pump inhibitors, which are used to treat acid reflux. And so many people have acid reflux and are on it. But there is a fair body of evidence suggesting that there is an association between increased use of proton pump inhibitors and the development of a type of kidney disease called interstitial nephritis. I have seen this in clinic. I have asked some of my patients to perhaps consider alternatives, but the acid reflux that comes back when these medications are taken off could be lifestyle limiting, needing patients to have some degree of use of these medications. So again, it isn't as easy as black and white. Yes, this is always bad. No, that is always good. We have to weigh the pros and cons of why the patient is on a medication. In fact, we put patients on immunosuppressive medications that can sometimes cause kidney damage long term, even after a transplant. So the medications that we give patients after a kidney transplant can in turn long term cause some degree of kidney damage. And the other large class of drugs that we perhaps should talk about are antibiotics. Most of us take some courses of antibiotics over the course of our lives, maybe one or two every few years. And there are some antibiotics that can increase your risk of kidney disease or can cause complications with electrolytes and creatinine values if you already have chronic kidney disease. And so that's why it's important to talk to your clinical team about your kidney function and ask if any new medications could either interact with drugs you're already taking or have a direct effect on your kidney function.
Excellent. And I think the key takeaway there is before you stop taking any of the medicines that you've been given by your doctor, have a conversation with your doctor about those medicines before stopping. Because you said many of the medications that people are taking, have their own purposes and you can't just stop them without talking to your doctor first. Um, Someone asked a question about spilling albumin and what does that mean and what does that tell a nephrologist?
That is a great question, and it's albuminuria or urine in the albumin has definitely come to the forefront, especially in the last month. For those of you who watched the Super Bowl, because there was we were highlighting that relationship between the cardio-kidney metabolic syndrome and what we test in the urine. Albumin is the most common protein that spills into the urine anytime the kidneys are damaged. We typically should have no albumin in the urine. But if the filter of the kidney is damaged, we start to see these albumin molecules, which are larger than the size of the filter pores, spilling through. Now, that filter, remember, is nothing but a clump of blood vessels. So while albumin in the urine is a sign of kidney disease, it could also be telling you about vascular disease as a whole everywhere. So if you've had uncontrolled diabetes, if you've had high cholesterol, the presence of albuminuria could tell us that you have vascular disease, not just in the kidney. You may have vascular disease in the eye from diabetes, for instance, and we know that these two correlate. So the other important thing we know is that the amount of albumin that people have in the urine directly associates with the increase in risk for both kidney adverse events and cardiac adverse events. So we work to try and minimize the amount of albuminuria that anyone has. In fact, I mentioned earlier that we use it to stage chronic kidney disease. Somebody who has a GFR less than 60, so maybe say 45, and has very low albumin in the urine, has a very different kidney failure risk compared to someone with that same GFR of 45, but has 500 milligrams or even 1,000 milligrams of albumin. So the risk is almost exponential. So it's not just a marker of treatment or treatment response, but it actually tells us about the future risks so that we can target therapies and intensify therapies to try and minimize those adverse cardiac and kidney events down the line.
Thank you so much. If you're just joining us, this is our Q&A with the American Kidney Fund Chief Medical Officer, Dr. Garamella. So please continue to send in your questions in the chat box, and they will get over to us, and we will answer as many of them as we can. One more from the audience that just come in. It's just come in, Pranav. Can sepsis have an impact on the kidney? And could you describe what sepsis is for people that do not know what sepsis is?
Absolutely. Sepsis is a process by which there is by definition, is a process by which there is an infection in the body systemically. And this typically results in low blood pressures and perhaps even end organ damage. So this could be damage to the kidneys, it could be damage to your liver, it could be damage to your blood vessels and your heart, meaning that you can't pump blood and keep your blood pressure up, in which case people get very, very sick and we call it septic shock. But just having a bacteria in your blood, even without having shock, does constitute sepsis. So it is a systemic feature. So I'm not talking about just having an infection in your finger, but rather a more systemic response. And that is because all of our organs are connected via the blood vessels. And so in the setting of sepsis, often if you have a florid bacterial infection or a fungal infection in your blood, these organisms do release mediators that can directly affect the kidneys. So you can see kidney injury in the setting of a bacterial infection in your blood, or if somebody has an infection in their valve. And very often we see patients who have a catheter put in for some kind of chemotherapy or infusions, which may get infected, and that could in turn affect the kidneys as well. So short answer is yes, sepsis has a very important and high risk association with kidney disease. And perhaps the thing to recognize is that it causes acute kidney injury, which is a little different from the CKD that we've been talking about. So very often patients who have sepsis may not have any kidney disease when they start off, but because of the blood pressure drops, because of the infection that's spreading to different organs, you may end up seeing a sudden rise in their kidney numbers. And this is what constitutes AKI, or acute kidney injury. Now, keep in mind that AKI, because of its nature of being precipitated by sepsis, can also improve fairly rapidly once the sepsis goes away. However, some patients may develop chronic kidney disease as a result of having developed acute kidney injury. And that's why acute kidney injury, especially in the hospital, is so key. Because patients, when they come in, they're thinking about infections, they're not thinking about their kidneys. And now all of a sudden they leave being diagnosed with kidney disease.
Does it get to the point where someone needs dialysis usually in the hospital with acute kidney injury?
So yes, it can cause it, but usually not. In fact, of all acute kidney injuries, only about 10% or so, 10 to 15% need dialysis care. Obviously, this percentage changes dramatically if you're talking about sepsis in the ICU, because these patients are much sicker. But the vast majority of patients, even with sepsis and acute kidney injury, don't require dialysis. But it's key to make sure that they are aware that some of the medications that they've been taking could be affecting that kidney function now, that they might need to adjust the dosage or the duration with which they need to stop these medications. And so getting that information across to their primary care, to their outpatient care teams, that, hey, somebody here had a problem with their kidneys suddenly, we would like these labs checked and these medications adjusted. That continuity of care really needs to be there so that patients don't end on to chronic kidney disease down the line.
Fantastic. So we talked a little bit about some of the new innovations that are on the horizon in vasculitis and Alport syndrome. What are some of the other innovations that are coming out or that have come out, and things that you're excited about? The next 5 years, what are you excited about for new therapies?
Well, I'm biased. I'm a nephrologist, so I'm excited about a lot of things. But the last 10 years have been pretty exciting. And I'll just recap perhaps what we've developed that has really improved outcomes. The management of chronic kidney disease, especially diabetic kidney disease and kidney disease associated with heart disease and vascular disease, has significantly improved. We used to be able to use ACE inhibitors and angiotensin receptor blockers, and that was really the end for about 20 years almost. But now we have drugs like empagliflozin or dapagliflozin, which are SGLT2 inhibitors, and they can help patients with kidney disease with or without diabetes, especially anyone with heart failure and heart disease. And so we are seeing rates of kidney disease progression decline with the use of these drugs. And of course, the addition of GLP-1 receptor agonists like semaglutide, which again work not just on the kidneys, but on weight reduction, on reducing that generalized inflammation that comes with obesity, helping the heart and helping the kidneys. We have a new class of drugs that work out through the kidneys called nonsteroidal mineralocorticoid receptor antagonists, or finerenone is the poster child of that class. And again, it reduces proteinuria in diabetic kidney disease. In the glomerular space, we have so many new medications now, especially for drugs like IgA nephropathy, which has had multiple drugs approved over the last 2 or 3 years. We have gut-specific steroids that are available. We have drugs that are targeting the BAFF and APRIL inhibitor pathway. We have drugs targeting the complement pathway in IgA. 5 years ago, none of this was available. And there are a whole host of molecules, especially for IgA, that are in the works. So over the next few years, I expect to see more therapies become available. And this is good because we know that not all patients respond to every therapy the same way. Some patients may have a better response, some patients may not respond at all. And that having the ability to change drugs rapidly based on each patient's phenotype will really improve our understanding. And I think the last thing we're really getting into is the use of genetics as we expand our understanding of genomics in kidney disease. Historically, we had a large unknown chronic kidney disease population. We are now able to test these patients using commercially available genetic tests quite easily. This is no longer a huge roadblock, at least in the United States. And so we're able to detect rare genetic diseases. We're able to detect familial disorders that are passed on. And we might soon be able to detect diseases for which we can develop specific drugs. For instance, there are drugs being developed for autosomal dominant tubulointerstitial kidney disease, or ADTKD, which is another rare disease, and for polycystic kidney disease based on the type of gene mutation. So I've said this before, and I'll say it again. I think we in nephrology are where perhaps breast cancer and oncology was 25 years ago, where the explosion of genomic and precision-based therapies is hopefully to come in the next few years.
I couldn't agree more. I mean, I started in the kidney disease space in the early 2000s, and I always tell people I started answering phones from patients asking questions, and I could rarely find a web page sometimes on things where now there's multiple, therapies available. So it's really, really amazing. You mentioned IgA nephropathy or IgAN, and the American Kidney Fund does have an IgAN campaign called A Step Ahead of IgA nephropathy. Once you go there, you can lead to another great organization that does a lot of fantastic work here, the IgAN Foundation, and they also, like the Alport Syndrome Foundation, also have a registry where you can get in there and learn more about trials and other opportunities. Question from the audience. Dehydration is often mentioned in kidney health. What is the right amount of hydration needed for kidney patients who are not on dialysis?
Excellent question. So we typically think about dehydration leading to a low blood pressure or volume depletion, as we in the medical setting call it. And this leads to a lack of blood flow to the kidney. And as a protective response, the kidneys may drop your GFR and stop filtering as much because they don't want to lose any fluid. And this can lead to some degree of kidney damage, which is probably reversible in most mild cases, but sometimes can be severe and cause acute kidney injury. The right answer is there is no one size fits all based on how hydrated one should be. And I appreciate the focus on patients who don't have advanced kidney disease, because in patients with advanced kidney disease, as they go through CKD 4, 5, and even dialysis, we know that excessive water can actually stay in the system, and rather than help, it can cause edema, it can cause volume overload and breathing problems. So I think that is a population wherein there has to be a personalized amount of fluid recommended based on some lab values and how they respond, whether or not they're taking diuretics, etc. For most patients, the recommendation from clinicians would be drink to thirst. And I know that can be challenging because sometimes we don't realize we're thirsty, then we realize we're getting dehydrated. Is there clinical evidence that drinking 8 cups of water a day helps? There honestly isn't. So when patients ask me, I have normal kidneys or I want to keep my kidneys healthy, how do I know I'm drinking enough? And I'm like, if your urine is not extremely concentrated, if your urine seems dilute, you're probably doing a reasonable job. Most people, unless you have recurrent kidney stones, you have some diseases like polycystic kidney disease where you're required to drink a lot of water, most people don't need to drink more than 2 liters to 3 liters of water a day. And the kidneys, if your kidneys are normal, are really good at getting rid of the water. So unless you're drinking 2 or 3 gallons, which hopefully nobody is, if you drink an extra few cups of water, your kidneys are going to excrete that in dilute urine. So the kidneys will handle it mostly. And as long as you realize that you're not feeling thirsty all the time, your urine is not concentrated and is either clear or light yellow, I think you are adequately hydrated.
Fantastic. Well, you mentioned one of the reasons that you might be advised to drink more water are kidney stones. And we just got a question, can multiple kidney stones cause kidney damage? And I'm wondering if you could talk a little bit about just what a kidney stone is, and what you would recommend for someone that's getting multiple kidney stones, because, there can be some other conditions that cause that.
Absolutely. So, kidney stones are a process by which the salts that our body normally excretes in the kidney, so these are usually salts of calcium, like calcium and oxalate or calcium and phosphate. And sometimes we have uric acid that is excreted especially if you have gout or high uric acid levels. And typically the urine is dilute enough that these salts don't get a chance to clump together and start forming a large crystal, which then attaches to the surface on the inside of the kidney, in the system that urine is formed in, or what we call the collecting system. And kidney stones can be caused by a number of reasons. We know that patients who have diabetes or gout and have obesity have a risk for developing uric acid stones and calcium stones. If you look worldwide, calcium stones are the most common cause of kidney stones. Patients who have urinary tract infections with certain bacteria are also more likely to have kidney stones because the bacteria produce enzymes that lead to the formation of these stones. They actually split these urea is forming bacteria can produce enzymes leading to kidney stones. The short answer to whether or not kidney stones can cause kidney disease is yes, and there are a few different ways they can do that. Perhaps the most significant and sudden way is if there is an obstruction of the kidney flow, urine flow, which means that there is no more urine coming out of that kidney, or over time the ureter, the tube that takes the urine from the kidney to the bladder, is getting blocked, and people may or may not be symptomatic. Sometimes these stones can actually form within the body of the kidney, and we call these staghorn calculi because they look like large staghorns. And in these cases, it can cause a complete obstruction. And this is usually a surgical emergency wherein somebody needs to take out that stone. So if kidney stones cause obstruction, they can absolutely cause both acute kidney injury and over time, even chronic kidney disease. The stones can also get infected. And so if you have urinary tract infections secondary to stones, you could also get chronic kidney disease from that. And so one of the things we recommend is increasing the fluid intake, which by definition will dilute the concentration of these salts present in the urine. But there are nuances and medications which we can prescribe based on urine analysis. So a 24-hour collection of urine will tell us whether patients are drinking enough, whether they have enough of citrate in their urine, whether they have too much calcium, and how we can try and manipulate the levels of each of these to make sure that we have a prescription that fits each patient's risk profile.
Fantastic. And if you're looking for more information on kidney stones, you can find a lot more on the kidneyfund.org website, including links to some of the organizations that deal with some of these rare disorders that cause multiple kidney stones, like the Oxalosis and Hyperoxaluria Foundation. You can find from our website as well. We have a question regarding potassium. This one's also a little bit nuanced as well. So I thought maybe you could start just by talking about the relationship of potassium and what it plays in relationship to the kidneys. But then the question specifically is, can taking potassium chloride to address low potassium cause kidney issues?
Very good question. So potassium is a commonly found electrolyte inside the cell. So typically most of your potassium is inside cells, unlike sodium, where most of the sodium is outside of the cells. And the typical potassium normal values range anywhere between 3.5 to 5.5, depending on the lab and depending on people's diet. We get nearly all our potassium from our diet. And so it's important to remember that patients who are not eating very high potassium foods may have a low potassium, and patients who are eating very high potassium foods, especially if their kidneys don't work, could have high blood potassium levels. And that's important because potassium is excreted by the kidneys. So as kidney function declines, as patients go from chronic kidney disease stage 3 to stage 5, their levels of potassium in the blood will go up. Now, we worry a little bit about this in advanced kidney disease because potassium values above 5.5 and definitely above 5.6 are associated with increased risk of cardiac arrhythmias and complications. Also, some of the medications that are critical for preventing kidney disease progression, like the ACE inhibitors or even the mineralocorticoid receptor antagonists, can increase your levels of potassium. So there needs to be a balance between our ability to use them to prevent cardiac complications in kidney disease and also the ability to make sure your potassium is in the normal range. Potassium chloride supplementation is very commonly used in a variety of settings. Some patients are taking diuretics or water pills, and when patients pee more, they tend to lose more potassium. So sometimes we need to supplement that with potassium. Patients with kidney stones often need potassium supplementation as well, and this is typically in the form of potassium citrate. Low potassium levels in the urine also can cause kidney stones, so we supplement them with potassium. In fact, potassium has a very interesting relationship with cardiac outcomes in people who don't have kidney disease. If someone were to replace all the salt in the diet with potassium, there is emerging evidence that that may be beneficial on blood pressure control and stroke reduction. And there are large trials where they've replaced salt for an entire community with potassium-based salts. Having said that, potassium is not directly hurtful or harmful to the kidneys. Potassium intake will not cause that, but if you have chronic kidney disease and you're on medications that can already raise your potassium, if for any reason you're taking a potassium supplement, you need to be cognizant of the fact that you need to have your labs checked and be wary of any other new drugs that may cause changes in your potassium levels.
Thank you. So this next question is around for transplant recipients and around immunosuppressant drugs. I mean, you heard, I think, in the very first session this morning, Rachel Meyer from ASN talking about transplant being really the best option for people that are in kidney failure. But some of the transplant drugs, as you know, have a lot of side effects, right? And there has not been a lot of innovation in the space for transplant medications in a very long time. So this question is very understandable. For transplant recipients, is there ever a point in time where the body fully recognizes the transplanted kidney, or are immunosuppressant drugs needed forever?
For the vast majority of patients right now, we still need immunosuppressant drugs forever. There are immune tolerance protocols that are being developed. There are stem cell therapies that are being tried to try and make the body recognize the transplanted organ. But unfortunately, right now, for most patients who are on wait lists and who are going to get kidneys in the foreseeable future, immunosuppression remains one of the backbones of making sure that organ lasts, notwithstanding the fact that immunosuppression comes with its own complications, infections, and side effects. And while we are getting better by using minimal doses of steroids and steroid-sparing regimens, we are changing immunosuppression to infusions in some cases, so patients don't need to take this every day. They can take infusions once a month. The immunosuppression um, going away is still a few years away, probably, but there are trials being done right now.
Okay. Well, we're just about out of time. And aside from our CEO, LeVarn Burton, who's coming up next, you have the last word here, the opportunity to give one last thing for the audience to know and maybe one last thing for them to do. What's something you would like to take away from Kidney Action Week?
Well, this has been an incredible week of learning, and I appreciate everyone joining. What I'd like to just say again is that chronic kidney disease is not a single illness. It's not a single entity. It's a spectrum. It can come from several different causes. And our job, working as clinicians and with the American to, with to, through and our job working through the American Kidney Fund is to help you understand risk factors, help you figure out how we can slow down kidney disease, treat complications, and not just protect your kidney, but also protect your heart and your life. And so, if you have questions, the good news is that we have more tools than ever. There are new medicines that are coming up. There are clinical trials that you might be eligible for. And so management of chronic kidney disease is very different today than it was a few years ago. And so I would really like everyone to be proactive in their care, ask questions, and use tools available around you to look up answers if you find that you still have not been provided with adequate information.
Great. Well, thank you all so much for joining us for Kidney Action Week, joining us for this session. I think it's easy to say these are probably some of the best questions I think we've ever gotten in one of these. So thank you for all of you that sent in questions today. Thank you, Dr. Garamella, for sharing your expertise with us today. If we didn't get to your question, don't worry. You can visit our website, which again is kidneyfund.org, for lots of great resources about kidney disease. As we wrap up this session, you will see a brief survey linked in the chat. Please take a minute to fill it out and tell us how we did. Your feedback will be very useful as we plan future sessions. In just a few minutes, we'll have our closing remarks with LeVarn Burton, who is the president and CEO of the American Kidney Fund. We hope you'll stick around to help us celebrate all that we've learned this week. Thank you, everyone, and have a great day.